the sector in standardizing services?
All right. That's a very good question. But before I go to answer your question, let me comment on your previous question, which is, I think, is very, very important. That when we are talking about medical tourism, we have to make sure that we personalize the services to our patient. Fatma and the caretaker are supposed to get a standardized treatment plan just before they left their country to come to Kenya, for example. They have to know for how long are they going to stay to the hospital, for how long the surgery will last, where the patient is going to stay, the language barrier, weather, transport, and all those kind of things should be a package that the patient should get before the patient arrives in the country. And post-surgery, where are they going to stay? Should we have hotel partners where they can go and stay? If they go to the hotel, what is the relationship between the hotel and the hospital? In case of emergency, what will happen? So those are the kind of things that we have to consider when we are doing medical tourism. So coming to the question that you asked, standardized care, like for the patient who is, Fatma has been treated here, now wants to go back to Tanzania or to, you say, Djibouti? Yeah, so I would like to quote the famous quote of President Yoweri Museveni. He said, in Africa, we have the unhealthy competition. And then he called it the competition of dwarfs, who is taller than the other. But they're all short. They're very short, but they're competing with taller than the other. So that's an unhealthy competition. In Africa, in East Africa particularly, we tend to compete. We have unhealthy competition. Like if somebody is trained in Kenya, he works in Kenya, but if he comes to Tanzania, he will not be allowed to practice. He will have to submit his certificates to the Tanzania University TCU Council, to certify his certificates such that he can be allowed to practice. But remember, we have in East Africa, we have East African Council of Universities. That one can, if we use that council, East African Council, can certify our doctors. And the doctor can move from Tanzania to Uganda, practice, without getting any hurdles. So we need to have, if we don't have that forum or that council, we need to form one. So, because a doctor who's trained in German can go and practice in Netherlands, just like that. So I think we have to do all of those things that are needed to make sure that we standardize care. So if Fatma is treated here, she goes back to Djibouti, she needs to get the same treatment that she got in Kenya. We need to have the body that can certify doctors around the East African community or around Africa, where if that doctor is certified in that body, then can provide care everywhere in this country, within the bloc. So that will be easy. Failure of that, then it will be difficult. You might get different services from here, then goes back to Djibouti, just a different service. Thank you.
And also continuation of care in her own country, Maybe the main big procedure that was only available in Nairobi has been done, but she needs to keep frequently seeing the doctor in her own country. So standardization at least ensures that she's well taken care of as she recovers. Thank you very much. Let me come to you, Dr. Omar. I know you are really involved in laboratory medicine. Some of the things patients are very concerned about, because they've done so many tests, by the time that they're leaving their country and deciding, I need to seek care elsewhere, do they have to repeat everything? Again, coming back to standardization, are do facilities recognize results from other facilities in other countries? How can we save Fatuma and Fazana from repeating a whole workup and save them cost? Is it possible?
Yes, and indeed it is possible, and it's not a new thing that you would see transfer of laboratory results by the patient to their primary clinician, who may be 5,000, 8,000, 10,000 miles away. I think the key here, again, to repeat what Dr. Ariya has said, is standardization. Laboratory medicine has its own quality standards. There is a whole ISO standard, which is ISO 15189 of 2012. That's the latest one till date. It comprises quality management systems set for quality and competency. So there is no reason to not accept a lab test that was done in Dar es Salaam in a qualified and competent laboratory and insist on saying that we'll have to redo these. There might be reason why someone or a clinician might request a repeat, and that might be if the result does not fit in with suspected expectation of the clinician. Say, for example, all of a sudden for the test X, the physician has been accustomed to a certain result from this particular patient, and then there's an upward or a downward surge of that particular parameter, and says, okay, could this test be accurate? Just to be safe and to be sure, they might request a repeat of that particular test. But again, I think you also look at the quality of the report when you evaluate. So in this particular context, for example, if it's a biopsy, right? By reading the report of the biopsy, you can try and have a sense of feeling the person behind that particular report. So for example, if it's a mastectomy specimen for investigation of a cancer, you see all the parameters of a mastectomy specimen has been reported, from the skin margins to the tumor, the type of tumor, the grading, the Nottingham score, superior, posterior, medial, lateral margins have been reported, axillary dissection status of the lymph nodes, how many lymph nodes are involved out of how many that have been harvested. I mean, you just look at the pattern of the report and you say, oh, this is a competent person who has interpreted this particular report, as opposed to a report that says, right mastectomy, diagnosis, adenocarcinoma of the breast, full stop. You look at that report and you say, okay, no, I need to look at this report again. I need to redo this test. But in the first criteria, you actually see the thought process of that particular pathologist right from the word go. And it's a focused, it is a systematic report, it is conclusive report, such that even the surgeon or the oncologist or the radiation therapist knows exactly what to do from that particular report. Yeah.
Makes a lot of sense. Yeah. And I think once providers establish linkages, once you've been seeing patients from a certain provider in the other country and you've established communication for a while, then you even get a baseline of what you need to communicate when you're sending a patient across, when you're sending them back.
Exactly.
Yeah, and that's what we need to develop in the region.
Yeah.
Let me come to you, Dr. Arab. I think you're representing providers. We've talked a lot about communication. What can we do to improve our communication as healthcare providers and healthcare professionals to the patients and their families, seeing as they're coming from different contexts, different countries, different languages, different religions?
Thank you. Going back to Fatuma, 87 years old, I'm really concerned about
Yes,
her.
Fatuma, Miss Fatuma, she has a bit of Alzheimer's,
Now,
which is not her primary issue.
the type-
And there's Fazana, who is speaking English.
The type of patients that we get in from across the borders. I get quite a lot of patients from Malindi and Mombasa who used to go to KCMC, now they come to Dar es Salaam, okay? Now, what is it? There are some patients who are walk-in patients. They just come in and you find out that they've come from abroad. And there are some patients who come in with all the documents and investigations as very nicely elaborated by Dr. Omar. So it is very important that we have these documentations in order. If we do not have the documentations, that means that you are repeating all the investigations again to reach somewhere so that you don't miss it. Having discharged that patient, we should ensure that we have actually parted with all the information that is there to be given to the doctor who is going to continue the care over there. So these are very sensitive parts, but very important as far as the patient's flow in and flow out is concerned. See? If we don't look at it, then we will have the same patient moving in the same place to another hospital, to another hospital. And so that way, the satisfaction of the patients is very important. The other thing, as far as a clinician, I would be very careful in reaching to the correct diagnosis and should be very open that this thing is not available here. Can you please go to that center or that center? And should be open with a good referral note. I mean, these ethical practices needs to be really observed when we really have these cross-border references. Okay? So I think these are the very important aspects in the medical practice, and also to promote, because the patient may have heard somewhere that you should go to X hospital because somebody got treated over there. So they will just walk in and say that now you treat me, you see. So these are the things these are very sensitive things, but at the same time, if we want to sustain good tourism, we want to sustain our reputation, and also to make sure that we have inflow of patients coming in, then I think these are the things that we need to do. Thanks.
Absolutely, absolutely. Dr. Tongun, we have so many federations here, actually from the entire region. Can we be a source of information for these patients? Can we be a source of information for the needs of this elderly patient in terms of cost, in terms of types of procedures available where? Can we have all the same information between all the countries? What's the role of the federations?
Thank you. First of all, we have all the federations around here, but in some cases we don't know what each and every facility does in different countries. So we know very well Tanzania may be strong in ABCD, Kenya may be strong in 1, 2, 3, and South Sudan is, well, still there, and a few other places. So part of our job as well as a federation is to unite our doctors, say going back home in South Sudan, and we can have a big impact on helping our Fatuma on that side in terms of changing their perception. Because we have a lot of cases where patients coming in, when they're referred to, let's say, Kenya or Uganda, they have this perception that they're going to be, quote unquote, robbed and have their costs inflated and everything else. And this is where we come in trying to address the cases and the issues. With standardization, for example, it's good. South Sudan is now part of the COSEXA, and it has been for a very long time. So across board, our clinicians and our specialists are getting the same, I would say, standardized treatment and courses and trainings all over, and actually get to meet their peers across in different areas. So it actually helps a lot in actually with, I would say, the referrals and everything else. The next thing is after standardization, we're looking at cost-wise. We need to know how much it costs to get things done in Nairobi, how much it costs to get it done in Kampala or whatever else, and other places in Dar. And the more you give us this information, then it's easier. Then other services, the third-party services that can be done. So, for example, a procedure could be very cheap in Dar and could be done with support from palliative care. And if we can be able to give that and provide that option, then at least the patient will be more informed and better, decide better on where to go. Or in some cases, we can say take them to Bungoma instead of having to bring them to Nairobi all through, whereby it's much cheaper. I mean, the cost of living in Bungoma could be much cheaper, and I can get somebody to come across from Kampala by road. So we can bring the patient to Bungoma by air and then get to cross by road. So the federations has a lot to do in terms of also selecting where to take the person, calming them down, mentally preparing them on where to go and what to expect when they get over there, the language barriers and everything else that they may have to go through the procedures, and also as well as informing them of the costs and helping them with issues with the visas and everything else. It's good that nowadays East Africa is visa-free, so this will make things a lot more easier in terms of coming in and not having to wait to try to get visa done, extensions, and all these other things that used to bring in extra stress and everything else. Thank you. I hope I've answered all your questions.
Yes, you have. And I'm changing the citizenship of Fatuma to be from South Sudan. So if Fatuma comes...
One more thing, just I think it'll also be good if we can actually get a proper digitized system. Mm-hmm. I know there's a lot of patients, our patients will come in as walk-in patients and will barely carry in anything. And it also has a problem when they're going back home.
Yeah.
A lot of them will also leave half of their x-rays and lab reports here. So whichever doctor is trying to follow up on that side also has to start from almost nowhere. So it'll be good if there's a system that you can actually integrate and share documents from different federations or through different federations.
And that comes back to Dr. Arab's point about communication. Everything that is needed to be seen on this side where she's coming needs to be communicated prior, because she can't just rush back and get her previous scans. So if Fatuma comes to the Association of Private Healthcare Providers of South Sudan, now I've moved her to South Sudan, and she inquires from there, she should feel confident that when in consultation with KHF or in consultation with AFTA, you send her to a provider in Tanzania, she should be very confident because of the credibility of the federation, she's not going to get robbed.
Yes, and that's one thing we should do. And it's not...
She's not going to a cowboy facility.
Yes, she's not going to a cowboy facility robbed is not the... overcharged was the word I was going to use. And it's much better because there's a perception that if you come to Kenya, things will be charged differently because you're a foreigner. And you have to also calm them on that side. Or if you go to X places, but just let them know that you'll get the same services which are available or not available on this side. Same price, same medicine, standardized in most cases, and it will get easier with you. And I can give you a quick example. The IGAD is running a cross-border program for TB and HIV patients. And it's looking at people across the borders dealing with refugee camps, for example. So they have now standardized treatment policies, but at the same time also standardized referral letters. So a refugee who has TB or HIV can actually cross, because sometimes you cannot stop them from crossing the borders, but they can actually move across from South Sudan to Uganda and vice versa, or Kenya to South Sudan and vice versa. And the clinicians on both sides actually do share a lot of information across from each other. And it's from small scale issues like this that we can actually bring it up further and try to improve on how it's done. And it's also the same between South Sudan and Ethiopia and Sudan and North Sudan. Yeah. So the treatment guidelines are more or less the same, just around the border areas. And it's through such collaborations that we hope actually to improve the federations and increase it now to a bigger scale so that anyone is comfortable to come, not only to, let's say, Nairobi, but can go to Bungoma, but they can go to Kikuyu. For example, PCA Kikuyu has a very good reputation in South Sudan based on the fact that they are linked with a lot of COSEXA. It's a faith-based, and they're linked with a lot of COSEXA trainings, and there's been a lot of trainings and things going on over there. So they'll be much more comfortable coming to PCA Kikuyu based on the previous reputations than it is to go somewhere else. Another reason, another things you can also do between the two federations is, as Dr. Ms. Gikonya said earlier, they do run clinics. It'll be good to organize some clinics and CMEs in South Sudan, whereby between the two federations, and that will also, one, educate our doctors who are there, and it'll make it easier to organize for any tourism or medical tourism to come in, because when our people are more informed on what choices they have, then it'll actually help the patient make the decision better and faster. Thank you.
Thank you. All right, I'm told our time is up. Your final comments, your final remarks, starting from Mr. Kumar.
I think what we spoke just now about the federation involvement is a welcoming initiative, because even today the most evolved healthcare destinations doesn't have this kind of facility. There have been incidences when people have traveled to the best destinations, I don't want to name the country, ended up in a very lousy facility kind of thing, because there is nobody to guide, to monitor whether the patient is going to the right facility or not, and things like that. My parting comment would be, despite all these things, as long as it's a patient-centric initiative and that passion, to make a meaningful difference in the lives of patients are there from all the equal stakeholders, I think we'll be there. Thank you.
I'm actually very impressed that the region is taking big steps forward in terms of improving health tourism, in not only just covering all the medical side of things, but the non-medical, the palliative care of things. Yes. And this is actually great information, and we actually look forward to expanding some of this into our country also to prevent them from coming to Kenya and other places. But rather actually we can give them more of these facilities and services, even though we already started doing in certain sectors and improving those sectors so that to improve things on that side. Thank you.
Thank you, Dr. Arab.
I would be emphasizing on standardization of healthcare services across border. We should be on the uniform so that the reference becomes easy, and should be a good collaborative understanding. Thank you.
I echo what my colleagues have said. One additional thing is to be aware of your surroundings. Say, for example, I'll give you a good example. For people living around Taveta, Taita, we have to realize that for them to cross the border and go to KCMC is so much easier than to come to KNH here in Nairobi, and probably cheaper. Yeah. Again, for a patient in Tarime, in Tanzania, it's probably easier to cross the border and come to Life Care and be treated, because Dar es Salaam is probably kilomita ngapi? 1,800? 1,800 kilometers from Tarime? Less than that. It's more than 1,500 kilometers. Wow. I know it takes 2 days to travel from Dar es Salaam to Tarime. Yeah? So, when we make such decisions, we have to take what is at stake into context. Because you might be creating something that will not only benefit your people in your country, but it will greatly benefit your neighboring country as well. Yeah, thanks.
Yeah, so for me, I think the final remark would be we have the federation in East Africa. So let us work as a bloc. Let us communicate. Let us provide information. Then I think we'll be able to move forward. Thank you.
Agreed.
Thank you. I'd like to summarize by saying personalized care is what we learned about today, making sure that we're looking at the family as a whole, not just the medical aspect of it. collaboration between the federations, critical communication, and I think upskilling our workforce towards that end, I think would be a great way to go as well.
Thank you.
For us, as an airline, we have seen a lot of unprecedented collaboration between the medical industry and air transport, even during the COVID pandemic time. And this has been an eye-opener, never like before. We have depended on the medical and health industry to be able even to help us to facilitate transportation of passengers. Remember one time the skies were shut, and it was a very not a friendly environment. And learning point going forward is that airlines are actually opening up to even provide personalized services for patients traveling as passengers. And they're coming up with tailor-made products, even in collaboration with the insurance and health providers, just to cater for this need that was not captured before. So even for medical tourism, we are seeing many medical practitioners going to international countries, exchanging education and training, benchmarking, and quite a number of percentages come from healthcare and medical services, being the frequent flyers of the airlines. So this partnership and collaboration is good, and we encourage that it can be continued and enhanced even better as we do best practices in the industry.
Absolutely. I think it's clear that we have the ingredients, we have the building blocks of making our region a preferred destination for medical care. And one of the big takeaways, there have been many, is that we can leverage on the strength, the presence, and the collaboration of the various federations and associations in our region to make people want to come to East Africa for trusted, quality medical care. So I think the role of the federations, we can already start to collaborate, talk, be a repository of knowledge. We don't need to have the disease called Serikali Saidia. Serikali doesn't need to Saidia so much. Initially, we can already come together and provide information and linkages between ourselves. But I think the final assessor of how well we are doing is the patient. So I'll ask you, have we provided good care for Ms. Fatuma and her niece Fazana? With the solutions that have been proposed today, will she get good care when she comes to East Africa, any of the countries in East Africa? Will she get information? I hear a yes. So I think you deserve a clap. Please give a clap to the panel. Thank you very much for your insights. Asante.
So thank you so much, Dr. Daniela. A better round of applause to our panelists. So at this particular point, I'd like to go to our next